In this video, we'll talk about antiphospholipid syndrome and how do we diagnose it in addition to management. So antiphospholipid syndrome, 50% of the time it's idiopathic, and the other 50% composed of two main causes, SLE and all other autoimmune diseases. SLE 35%, other autoimmune diseases 15%. Now, when do we think about antiphospholipid syndrome? So think about it when you don't have any obvious reason for the patient having venous or arterial thrombosis, especially when you take history from them and they mention that they have a history of pregnancy with miscarriages or premature birth. Also, if this is not their first arterial venous thrombosis, that will make you more suspicious about having antiphospholipid syndrome. Now, let's talk about the exam findings that make you consider antiphospholipid syndrome part of your differential. First one is a new valvular disease, and this is caused by autoimmune endocarditis, which is Liebman-Sack. Important to keep in your mind that Liebman-Sack endocarditis does not prevent like infective endocarditis. Here we have autoimmune response. Usually they present with a valvular disease like aortic regurgitation with its complications like shortness of breath, for example, as well as stroke manifestations. Why? Because we have these vegetations causing emboli going to the brain, causing stroke symptoms. Next, we have Ligature Reticularis, which can be present in around 20% of the patients with antiphospholipid syndrome. So the idea here, we have thrombophilia, and the thrombophilia causes clots to form, including in the skin capillaries. Once they form in the skin capillaries, the blood there won't be oxygenated, and so it will turn into bluish in color, and that can appear from the skin. So we can see the capillaries as lace-like appearance, which we call reticularis. And then the last exam finding that might be present is the one that we mentioned, secondary to Liebman-Sack endocarditis mainly, where the patient develops strokes and decreased cognition secondary to multiple small emboli. Now, after history and exam, and you think this patient might have antiphospholipid syndrome, at that point you decide to do lab tests to confirm your diagnosis. And these labs, we are talking about antiphospholipid antibodies, including three common antibodies: anticardiolipin and lupus anticoagulant, in addition to beta-glycoprotein. Now, to make the diagnosis, you need the presence of one of each of the three categories we mentioned. You need one history, one exam, and one lab finding. And for the lab abnormality, it should be confirmed again after 12 weeks, which means you won't be able to diagnose antiphospholipid syndrome until 12 weeks after starting working up the patient. Now, important to know other laboratory findings, not needed for diagnosis, but for you to know and to understand how this disease and how to differentiate it from other diseases as well. PT is going to be normal or slightly elevated, while PTT is going to be elevated, and platelets are going to be low. If you think about it, this is unusual for thrombophilia that has PT and PTT elevated in addition to platelets being low. So the idea here is antiphospholipid antibodies attack the intrinsic and extrinsic pathways, more in the intrinsic pathway because phospholipid is an important part of the intrinsic pathway more than the extrinsic pathway. Now the question is, if we are causing prolongation of the coagulation cascade, then we should have bleeding. The answer, that's true, but there are other mechanisms that can cause thrombosis without interfering in the coagulation pathways, and that's what scientists presume as the mechanism of antiphospholipid antibodies causing thrombosis formation. Some say it is more of activation of the platelets, some as well say it is more an inhibition of protein C and S, which will increase the thrombosis formation. Now, for treatment, they might confuse you and put for you treatment options warfarin and DOACs. And you want to choose warfarin because they are the ones that are studied and proven to be effective in these patients. And you can add aspirin if you think this patient has arterial thrombosis and they are high risk atherosclerosis present in their arteries. Now, what if you were able to diagnose a patient with antiphospholipid syndrome without the presence of a thrombosis? Would you give them anticoagulation for prevention? And the answer is no, because there is no evidence or studies that show there is a benefit from doing that. And this is a potential exam question, so keep it in your mind. And that's it for antiphospholipid syndrome. Hope you guys learned something. See you in the next one.